Fala pessoal, estamos aqui no nosso terceiro episódio da nossa quarta temporada com um convidado internacional. Nosso podcast é internacional, vocês sabem disso. E diretamente da Inglaterra, Léo, temos Ben Cormack. Fala, Léo, tudo bom? Hello, Ben, how are you?
Very well, my friend. I'm sorry, my Portuguese is very bad.
It's
Fala,
like our
galera.
English, no problem.
Good,
Direto
good,
da
good.
terra do
Because
rei,
we
o
wouldn't
Ben.
go very far in Portuguese. Bom dia.
Bom dia.
Yeah.
O Ben, para quem não conhece, é um cara fantástico que tem uma atividade muito grande no YouTube e no Instagram. E ele tem uma página chamada CorKinetic, que ele fala sobre fisioterapia, sobre mecânica, sobre dor, sobre fatores psicológicos. Ele tem um material muito bom, é um cara que estuda muito. E a gente quis trazer o Ben porque ele tem uma coisa muito legal para falar para a gente hoje, né? Nice to have you here, Ben. It's a pleasure to receive you, to have you here on our podcast, and we hope you have a great time here today.
Yes, well, it depends how difficult your questions are. If your questions are very difficult, maybe it won't be so good. But if they're nice and easy, we'll be fine.
For our audience know you, you have the Instagram CorKinetic. That's it. And YouTube, do you have a YouTube channel?
Yes, but I'm very lazy and I probably don't update it as much as I should. I'm CorKinetic on Twitter, even though Twitter's dead. On Instagram, bit of YouTube. I also run the Better Clinician Project as well, alongside Adam Meekins. So that's another one of my kind of pages, etc., that people can probably find me through.
Okay, and we are going to start our podcast with for the audience know you a little bit better. And you were born in London or another place?
No, I am the last of the dying people of London. So London now, everyone leaves London, but I am yes, I am a Londoner, one of the true Londoners.
The last, one of the last.
Maybe one of the last, because lots of people come to London, and then Londoners seem to we get priced out and we have to move. And
Okay, and we have our first question here is our nostalgia moment. What do you remember when you were a kid or you're a teenager? What do you remember? What makes you a nostalgic moment of your life, and you want it to come back today? What do you remember?
oh, so okay, so I didn't know whether this was going to be nostalgia from the kind of rehab world or nostalgia from life. Then that's a bigger question. That's very deep, very philosophical.
Tell
All
us the
right,
one
so
you miss the most.
yeah, so I'm going to answer it two ways, actually. So my first answer was going to be related to kind of rehab and social media and these type of things. But that wasn't when I was a kid, because, that was more recently than that. What would I like to have in terms of nostalgia? Well, I think just, life being a little bit more chilled, for me, I think we've become very fast paced. We've become, certainly in London, in the UK, it's become very busy, and maybe a little bit more peace and serenity and these type of things. Because, I think if we look at pain and if we look at, our work stuff, how much stress relates into that. And for me, I think one of the things that nostalgically, I think the world maybe 20, 30 years ago was a little calmer, a little bit more chilled. not so much. In fact, what would I like? Maybe I would like less things like social media.
So we are talking about
go back to a time before social media and have some of that in our lives.
Before Orkut. Do you remember the Orkut, the first social media?
Sorry, say that again.
Orkut, Orkut.
The social media from 2004.
Oh, well, there were a few. There were some really early platforms, wasn't there? That happened. But probably for me, the first big social media platform was like Facebook and those kind of things. But you know, it's maybe a world sometimes where we are less connected, not more connected, or we are connected in ways that are not digital. You know, because I think we have become very digitally connected, but I think sometimes we are less personally connected. And I think that can be really, really challenging for us from a societal perspective, because people aren't so great.
Yeah,
people aren't so great.
Connection to others.
Yes, yeah. We lose our connection to other people. And I think that changes our personalities. I think that makes us less empathetic. I think it makes us less caring. And, you know, I think that affects our jobs today, in fact, that, you know, we are more digitally connected, but potentially less personally connected. So a bit of nostalgia for just more personal connection, I think, is really important.
Just to situate us on time, how long have you been a physiotherapist?
Well, my background is in the UK is what's called sports therapy. So what that means is that it's really the musculoskeletal side of physio, if you like, if we could describe it like that. And it's more designed, originally it was more designed for working in sporting populations, but over time, you know, they've started to kind of integrate sports therapists into the NHS, and you know, it's yeah, so very similar, but also a little bit different as well. But in answer to your question, I qualified in the early 2000s, around 2001. So that would mean I've been working clinically for 24 years.
Like us.
So a reasonable amount of time.
Same as us.
You are 47, 46.
I'm
Here.
46. I'm 47 in 3 weeks' time.
Oh, happy birthday in advance. Sorry.
Well, soon. I don't want to get there too quickly, my friend.
Okay.
Don't rush things.
Yeah, don't rush things. So it's you know, when you're 21, you want to be older. You want to, you know, and then when you're 46, you want to be younger again.
Okay, we need a little bit more time to enjoy our fish and chips.
Not for me, bro. I'm not a big fish and chips fan.
Really?
No, I don't. I don't enjoy it. British food can be a little boring sometimes. I like a little spice in my life. You know, fish and chips is.
They say,
yeah,
there's no British culinary, right? There's no British cuisine.
Yeah, well, look, you know, the thing about living in London is there is cuisine from the world.
Yeah.
If you want Brazilian cuisine, you can get it. If you want Thai cuisine, you can get it. But Northern Europe, so Germany, UK, you know, that part of Europe, we like heavy food. It's cold, guys.
Yeah.
You need heavy food like potatoes and meat. And, you know, we're not like the Spanish and the Italians, and, you know, they do it very well, right?
Yeah. The one thing I like
how's
on the British...
the weather? So how's the weather today?
Grey, miserable, boring.
Rainy.
A little...
Very London.
Yeah, exactly. So we are an island, right? And we have island weather, wet, grey, but not too cold. So we don't get too cold, but we also don't get too hot either. It's not the Copacabana.
Okay. Okay.
The one thing I like on the British cuisine, I learned how to do it. It's the Yorkshire pudding.
Well, that's just pancakes.
Yeah.
So it's the same pancake batter. Is Yorkshire pudding. You just cook it different.
Pancakes.
Yeah.
All right.
Very nice. You bring us a paper for our discussion. Let me put the paper here so we can talk about.
Tell us what do you want to talk about? What you want to talk about today? What you want to discuss with us?
Yeah. So the reason I chose this paper to talk about was that I think it's applicable across musculoskeletal treatment. So the title is quite specific to the idea of psychological factors. And the paper does talk about psychological factors. But one of the things that I found really interesting and things that we could learn across the whole biopsychosocial spectrum is about our ideas of what causes pain or what has an effect on pain. And what I think was fascinating from this paper was their discussion of causation in 3 ways. So one of the things that I really liked they were talking about, and that's what they're talking about, the 3 basic tenets or areas that go into understanding causation. Okay. So one of them would be what puts us at risk of pain, right? And so I don't think we often think about those factors. So we have risk. We also have what initiates pain. And that's the thing that we most often talk about. You know, my patient bent over, his back hurt, it must be the disc, right? Yeah. And then we also think about the idea of what maintains the problem. And that's maybe where we start to think about things like nociplastic pain.
The patients usually change their names for the problem. I have hernia, I have protrusion, I have discal problems, so I don't have a name anymore.
Catastrophizing sayings.
Yeah, I think people remember what they think, you know, hurt them, right? So because it hurts when I bend, well, that must be the reason this happened, right? You know, but if you look at, let's take herniation, for example. If you look at the risk factors for disc herniation, well, we see things like smoking is a risk factor. If you look at things like body mass index, for example, and although body mass index has flaws as a measurement, you know, it relates to things like adipose tissue and excess adipose tissue. So actually, it might not just be the bending over and the disc that caused the problem, but it might be things like our lifestyle, our body composition. And I think that's really important for us to appreciate and understand is just because something happens, we initiate pain and bending causes that pain to happen in that moment. It might not be that's the only thing that has contributed to having that problem. And I think that can be really important for people to appreciate that musculoskeletal pain is not just caused by movement or load or tissue. It also is systemic as well and goes across potentially the biopsychosocial spectrum.
What psychological factors really matter, do you think, for pain outcomes? What's the main that you understand in your clinical practice?
Yeah, and I'd like to say where I think psychological factors actually fit in. Because when it comes to direct causation, I'm not sure I see a big amount of evidence that says how we think has a huge amount of effect on the pain that we experience. So does thinking in a certain way, or having certain beliefs, or having psychological factors, does that actually cause us to have pain? And I don't think there's a lot of evidence there. Does psychological factors turn up nociception? I don't know. I'm not sure that we have great evidence for that. But I think where psychological factors do play a role is in how they affect our behaviors. And that might be that if I have a back problem and I develop fear avoidance, for example, how does that affect potentially how much we load the tissue? How does fear avoidance maybe affect how much we use our bodies, our health? So it might not be that psychological factors are initiating pain or even a risk for pain. But I think when we have pain, psychological factors often modify our behaviors, and our behaviors have a big effect, I think, on what we experience metabolically, what we experience physically, and those type of things. So it's important where we think about psychological factors. I think they probably maintain a painful problem rather than start a painful problem. But one of the big prognostic ones that I think we see, and obviously prognostic is to some degree predictive, it might not start the problem, but it might have an effect on the outcome. Does that make sense? That, we often want to know what started it, what caused it. And I don't know how much psychological factors do that. But I certainly think they may maintain a painful problem. All right. So one of the big things.
Yeah. I'm sorry. Could we think also that psychological factors are also modulating the behavior of the problem? It's a modulating factor, and also maybe a marker, just accompanying the process without causing anything, but it's present on the catastrophization, reflecting the stress or the belief system and driving the behavior of the person. That's when the marker elongates the process of healing. Can we think on this way also, thinking of psychological factors as a modulating and a maintaining, a modulating factor and a marker for the process of treatment, of rehab?
Yeah, well, I think that's really interesting, is if you think about the idea of maintaining a problem, it doesn't always tell us the mechanism. Yeah. So a prognostic factor isn't a direct reflection of a mechanism. We don't actually understand how psychological factors play their role. So we know they can be prognostic. So I think the biggest prognostic factor that we see, certainly in back pain, is my perception of recovery. So if I do not believe that I'm going to recover, it seems to be a marker of recovery. But what it doesn't tell us is mechanistically how it exerts that effect. So a prognostic factor is not a mechanistic factor. So the question is, how does it modulate outcomes? And at the moment, I don't think we know. I don't think that's as clear as it could be. So could it act in the short term? So could we have an element of descending modulation, that we create an anti-nociceptive, chemical environment that reduces what we experience in terms of pain? That could be a factor. Although that would only be a short-term factor. I think more than likely, it stops us engaging in positive prognostic factors. So when we are not motivated with our rehab, we're not going to do the exercises. We may not have behavior change. We may get stuck in the same cycles of behavior. And I think those cycles of behavior have an effect on the outcome. How much I use my back in terms of flexing, how much I use my back in terms of generally, how much I use my body in terms of health and fitness. But what we don't know exactly is why. So prognosis is not, a prognostic factor is not a clear mechanistic factor. So, you know, understanding that I think is really important.
Let me just ask you one thing that another nostalgic moment.
Okay, buddy.
When your head as a physical therapy, sports physio, changed because you had 20 years of graduation. And 20 years ago, we used to have a mechanicist way of working as a rehabilitation. When do you change since you start working, and how it was? How hard was that?
So I think about myself like Taylor Swift. You didn't expect this answer, right? You've opened a box. So the reason is because Taylor Swift has what she calls eras. So she has her eras tour. In her different eras, she has different styles of music, different things. So I started off like everyone else. I learned, you know, kinesiopathologically, finding the problem, fixing the problem. If it was weak, you strengthen it. If it's long, you shorten it. If it's, you know, tight, you stretch it. You know, we all learned like
the psoas myth.
Yeah, exactly. That, you know, my posture is a certain way. I stretch the hip flexor. Suddenly the pelvis works beautifully. We have no problems, right?
Yeah,
And
right.
for some people it worked brilliantly, and for other people it doesn't. But I think over time, and this is one of the things that I really wanted to talk about from a nostalgic perspective when you think about, you know, physical therapy, is that we don't learn as deeply anymore. So when I started my career in coming, not just being a clinician, but being a teacher, being a personality, we did that through things like blogs. We used to write blogs, and people used to read blogs, and we used to have deeper learning. You know, people were interested in research, not just in a 30-second Instagram reel, right? So if you want my kind of clinician nostalgic moment, it's about going back to deeper learning. It's about people having longer attention spans and actually are willing to go deeper into the problem. And so for me, my desire was to go deeper into understanding things. So I had a biomechanical era. I've had a pain science era. I've had a brain era. I've had a biopsychosocial era. And so over time and continuing to learn and wanting to know more, I've experienced different ways of working, from explaining pain rather than explaining biomechanics, right? You know, and then realizing that these things are never the answer. There isn't a single thing that is the answer. And it's being open to learning. When you are open to learning, you tend to be better. And I think that one thing we see today potentially is people want their opinions very, very quickly validated, rather than challenging themselves to learn deeper.
Yeah.
And for me, I think that's super important from a progressing standpoint, is that we still need to go deeper. And that means understanding more about social factors, understanding more about psychological factors, understanding more about biomechanics and load. You know, they all have a relevance, but it's a desire to have knowledge, not always have the answer. And I think for me, that's the key, is how do we keep understanding the bigger picture?
Okay. And how do you see manual therapy like osteopathy, chiropractic, and the role of musculoskeletal pain? How do you, because we have here in Brazil a problem that osteopaths, chiropractors seems like a god. I do everything. I know everything. I can fix everything. How do you work with this?
I think one of the problems potentially with osteopathy and chiropraction is sometimes it feels like it's a fixed knowledge, that people have the knowledge. They go to university, they learn, and they're quite sometimes a little fixed in the way that they approach musculoskeletal problems. And I know some brilliant osteopaths who embrace a wider, broader understanding, maybe a more biopsychosocial understanding as well. So I think that chiropractors, physios, sports therapists, osteopaths, in many ways, it shouldn't look too different. Because that means we're not working from the same knowledge base. And I think we need to be working from a very, very similar knowledge base rather than having different views of the body, because physiology is across all of us. Biomechanics is across all of us, right? So I think we have different ways of doing the same thing. So my view of manual therapy is, if you want to do manual therapy, then do it, right? I don't really give a shit what people do. But I do care that people have good communication. I do care that people have good examination. I do care that people understand it's more than just how well your spine moves or the alignment of your spine. So manual therapy is one way of influencing the human. So if you want to do that, brilliant. But it's not the only way, and it's not a comprehensive way. Because health matters, lifestyle matters, psychology matters. And if we think it's just about how well your spine is aligned, then you are missing a lot of really, really good information. So manual therapy can be part of the picture. It definitely isn't the whole picture.
I think the core issue of our practice today is that we have this gap between the excessive amount of techniques being taught and the deep comprehension of what is causation, what is prediction, and how to build a diagnosis that makes sense and then directs the practice, the treatment, the things that really matters, not just the likes, the shares, and the show that some folks put on internet, on Instagram, to show how good they are on performing a technique. We feel that we are missing the main point of our profession, that it's understand the wholeness of a person that's suffering, that's in distress, that can't cope anymore with the pain. And our job is to find the direction of the cause, maintaining factor, what modulates the course of action, the course of pain, of the stress, and the markers of insecurity, catastrophizing, and how we can promote health and well-being to this person. And we three here, we're close to the 50s, and we have 20, 24, 25 years of practice. We've learned from the very basics of our profession how to construct a diagnosis, and we see the profession going to a place that's no longer real. And what you show us today and what you bring us is something that's very, very necessary. Is to go back and learn how to find cause, prediction, maintaining, initiating factors, modulating factors, how to build a diagnosis. And personally, I find your page on Instagram fantastic, because you bring us things that make sense. You push us to think about the sense of things, and we have to act. We have to move to another place, and we are being obliged to teach all over again the basics of an exam, a physical exam, taking history, looking into the things that differentiate a risk factor for a initiating factor, a modulating factor, a maintaining factor, what is nociceptive pain, nociplastic pain, neuropathic pain. It was just so easy before. I don't know why this mess, this confusion we are doing today.
Well, I actually think if we go back about 10 years ago, I think we, you know, and again, this would be my nostalgic moment, is I think we did start to get into a deeper learning phase. If you look back at social media platforms like Twitter, for example, 10, 15 years ago, there were some great discussions that were had. You know, you had some really great researchers. You had, you know, simple people like me, Adam, you know, and various other people around, you know, Greg Lehman and Todd Hargrove, people that were having good discussions, writing good blogs, trying to have good conversations. And then I think what's happened with social media is it's not so much about good knowledge anymore. It's about, can I do something that gets emotional likes? Like, you know, can I show my amazing technique for manual therapy while I've got my top off? Or yeah. Can I, you know, and again, that's the real problem here, is that we, you know, I think we kind of peaked maybe a little bit, right? Where we are talking about the biopsychosocial model. We are talking about, you know, what has an effect on people, not just pain, but also the person experiencing that pain as well, which actually might be a maintaining factor, right? You know, we want to know what caused it. Well, maybe we need to know what causes it to carry on. You know, that's another question.
Yeah.
But it's really about, how do we understand a bigger, wider perspective of human health? And pain fits into that. But so does non-communicable disease. So does mental health. So many of the risk factors for pain are also risk factors for mental health. They're risk factors for mortality. They're risk factors for depression, anxiety, diabetes, high blood pressure. You know, so if we just think about spinal dysfunction as the cause of back pain, and all you need to do is click it back into place, there's going to be a lot of people that are going to have long-term pain because it's not the full picture. And how do we know it's not the full picture? Well, that's why we have research, not just about, is exercise better than manual therapy, but diagnostic research into the tests that we use, research into wider systemic factors, research into psychological factors, research into prognosis and prediction of outcome. And we get very interested in, is treatment A better than treatment B? Yeah. I don't give a shit about treatment. It bores me to tears. I don't care. You know, that for me, is manual therapy better than exercise, is the worst question ever. Who cares? What I really care is, did you communicate well? Did you do a good exam? Did you make this person feel cared for? Did you look at their life overall? Not just which treatment or technique did you use, or what method are you? That stuff just is boring. And it's going to take us backwards, not forwards.
Yeah. What do you think? The paper suggests lessons for next generation. Okay. What do you think are the biggest methodological blind spots that we have right now?
In terms of research or clinical practice?
Both. Clinical practice. And also,
yeah.
Sir. Okay.
Both. Yeah, there we go. So let's take clinical practice first. Okay. The biggest blind spots we have are that we don't appreciate enough how our world and our life and our ecosystem affects the person in front of us. And that goes back to what's the best exercise? What's the best technique? You know, what's the best metaphor for pain, right? And all of those things can be helpful, but they're probably not better than creating a really good space for that person to connect with you, right? So a lot of the times, you know, we need to keep focusing on what are the factors that affect things like positive relationships, behavior change. You know, what are the things that, again, put our patients at risk or maintain their problem, not just which structure is it affecting. Because, you know, a lot of what we do is kind of, you know, and there's nothing wrong with trying to find out which part of the body hurts, but that doesn't always tell you why that part of the body hurts. It doesn't tell you why it's not getting better. Right. And so it's fine to have a source of the problem. And people argue a lot about, is it a facet? Is it a disc? And that's great. You know, you can argue about that. Good for you. But at the same point, what is stopping this person getting better? You know, that's one of the challenges, isn't it? It's great. I can stand up and go, yeah, it's your facet or it's your disc. Is that predictive of a good outcome? That knowledge, does the knowledge it's a disc dramatically affect the outcome? Is it a prognostic factor? Can we selectively treat a disc versus a facet versus a, you know, you can argue about all of these different things. But when you look at prognostic research, accuracy of structure doesn't seem to relate very well to outcome.
Yeah.
Or treatment, particularly. You know, so I think for me, it's thinking about what research, you know, from a clinical perspective, it's being aware of some of the broader research that we have. From a research perspective, and I'm not a researcher, I'm just a guy who talks a lot, it would be really just trying to ask good research questions. And I think we have a lot of research questions like, what's the best exercise for back pain? And we have a lot of the outcomes that are very, very similar. Again, and oh, there isn't one, there isn't one, there isn't one. But let's do another piece of research, right? So actually, what are really good questions? And if you can have a really, really good research question, then you're going to have a really, really good piece of research that influences, you know, clinical practice. So what would be a great piece of, so, you know, if you look at, is painful exercise okay in rehab? How much pain seems to be something that people can handle or manage or tolerate before it affects outcomes? That's actually a very, very clinically relevant piece of research. Right? Another systematic review about what's the best exercise probably isn't a really, really good, relevant piece of research. So what's the question? Are we asking really, really good questions? And again, you know, that's probably above my pay grade as a very simple clinician educator. But, you know, I think being aware of research from a clinical perspective, and then from a research perspective, the future is better research questions.
Yeah,
for sure. And if you were designing a new clinical trial today, what key factor would you include and how would you measure it?
So I think if I was going to design a clinical trial, and no one's going to let me do that, so this is very theoretical. So I would like to look at...
First of all, no one is going to make me...
Yeah. No one's going to let me do that. But anyway, and I'm not qualified to do it either. So, but I would like to see pain self-efficacy explored as a primary outcome measure. Because at the moment, we have a lot, it seems to be a strong prognostic factor. So people's relationship with pain, how much they're willing to experience a bit of pain in their lives and in their, when they do their activities, you know, my relationship with pain, how much it affects me. I would like to see that as an actual intervention, not just a secondary outcome measure. Because at the moment, I think we use it as a secondary outcome measure, but without designing interventions that may have an effect on it, and without using that as a primary powered outcome. Because, you know, when you do a trial, a secondary outcome measure isn't powered, is it? You know, you power for the primary outcome measure. And so the secondary outcome measure is, you know, not as relevant as the primary one. So I think from that perspective, I'd like to see a little bit more of a intervention and at primary outcome measure design, not just a secondary outcome measure design, because then we can turn prognostic factors into intervention. Does this prognostic factor have an effect on outcomes? Because at the moment, one of the challenges is it is a predictive factor or a prognostic factor, and those two things are similar but different. But is it interventionally relevant? Can we change it? And that's a key question. That's the difference between prognosis and intervention. Can you change the variable?
We did an episode with Gerard Alvarez. That is, he talk about
preference trials.
Preference trials, for example.
Okay.
There is a patient with low back pain that loves movement and exercise. And there's another that loves manual therapy. If you change the preference, you are really gonna change the outcomes. Do you agree with that?
Yes and no. Yes and no. I saw, and this goes back to, I think they looked at preference driving. I think Joel Bielowski looked at that as well. Maybe 2010, 2014, I can't remember. But, you know, there's been some other research into preference. And sometimes it seems to have a positive effect, and sometimes it doesn't seem to matter so much. So if your pain is heavily affected by your lifestyle and your health, I doubt preference matters very much, because it's systemic, isn't it? Do you see what I mean? It's like, if you know, if there is a systemic problem that may need to be affected via, you know, reducing systemic inflammation or, you know, something anti-nociceptive, anti-inflammatory environment, you know, and we are getting a little mechanistic there, I very much doubt your preference for manual therapy is going to significantly affect that. Right? But if it's something that requires pain modulation, so simply, am I creating descending modulation while my biology fixes the problem, right? While my immune system gets to work, then it probably doesn't matter, right? So I think it might depend on what's having an effect on, you know, why does someone have this problem? So I think if the problem is fairly simple, you know, in terms of maybe there isn't a big systemic issue, or there isn't, you know, something metabolic or this type of thing, then I think preference probably matters. But I think if it's something more metabolic, systemic, health related, then I think preference may be less important, unless it has a big effect on behavior. So where might preference matter is, you know, we know that being more active can help. You know, we know that being more active can be protective for back pain. You know, it reduces risk. The odds ratios drop. So in that sense, does my preference for which type of exercise matter? Probably. But does my preference for exercise or manual therapy matter? Well, I don't see why manual therapy would particularly affect my health. So yes and no is the answer to that question. It probably depends on the person and what their current state of their system is like. Again, it comes back to the biopsychosocial model, really, doesn't it? You know, if we took someone with a very, very low socioeconomic status, very poor, living in a very, very bad environment, well, it may not matter what your preference is for anything. Do you see? Both of them may not move the needle. So I think it's a yes and no question. If you love manual therapy, is manual therapy the answer to your back pain? Absolutely not. Because there are lots of people out there who get a lot of manual therapy, really like it, and still have back pain.
Yeah.
Just changing the subject and also linking to the things you just said. Let's talk about temporality. How the temporal misalignment how can we work on pain self-efficacy as a primary outcome and dealing with the temporal misalignment? Because there's this thing that we see on the trials today, is that we just have that window of time where we say, well, manual therapy works, exercise works on the short term, mid-term, long term, but we really don't measure the events along the time it's occurring, and then this changes, this temporal misalignment falsifies the direction of the relationship between cause and the fact. How can we change that on our trials, on the research, to solve this problem? How do you see that? And another thing, how do we work with the concept of overlapping conditions on one patient? Because you just hurt your leg, but you have depression, you have problems at work, at home, you have expectations there, you have metabolic conditions all together working on your body. So how do we overcome these problems?
Let me answer that one first. So we know that people with chronic lower back pain often have multiple comorbidity. Right. So is a few clicks and adjustments of my spine likely to have a big effect on that? No.
Of course not.
Is doing a few core stability exercises likely to have an effect on that? Of course not. Right? In the short term, and I'm going to answer both questions at the same time. In the short term, could both have modulation of my pain?
Yeah.
And I think this is where we get confused, is that we have a lot of different interventions, whether it's cupping, needles, exercise, whatever you want to talk about. Do they all have a potential short-term modulatory effect? Because, you know, and a terminology we use is non-specific. So what non-specific means is that the specificity of the treatment, so the type of exercise or the type of needles or the cups that you use or the technique manual therapy that you use, does that produce a specific outcome tied to the technique that you've done? And actually, there are lots of different ways of stimulating the same short-term modulatory effect, whether that's perceptual, whether it's mechanical input into the spine, you know, whether it's descending modulatory opioids and cannabinoids and GABA and, you know, all of these different neurotransmitters that we have. So I think what that does is it makes us not see the longer term picture. And if you were to say to me, actually, what is the best treatment over the long term? Well, I would have to say exercise, because it's the one that's most likely to create epigenetic change. It's the one that's most likely to have an effect on my, you know, immune system function. We know that people who are more active, that are fitter, tend to experience less pain and less severe pain. And one explanation for that is that, do they have a better system for dealing with pain? Is it more anti-nociceptive? Is it better in terms of healing injury and, you know, and in the interleukins that we have predominantly are more anti-inflammatory. So I think exercise over the longer term does create better systemic changes. And it's probably more likely to affect our overall health, comorbidity, these type of things, right? But in the short, but also changing someone's behavior into a positive ecosystem is really, really difficult. And it's affected by socioeconomics. It's affected by genetics. It's affected by so many variables that it becomes very, very difficult.
It takes time. It takes a long time to do that. Yeah.
More time than we have to research.
Yeah.
So, you know, it's sometimes at the moment we're better at recognizing the problem rather than fixing it. That's the stage we are at. And I think it's important for us to recognize. If you look at CFT research that came out recently, the Restore trial, it had really positive benefits for pain. You know, we saw the MCID, the minimal clinical important difference, reached what we would call significant, right? So it got kind of over that magical 2 on a 11-point VAS. But on average, people still had 4 out of 10 pain. So we are not there yet. We are not even close to being there. You know, we are only really understanding the problem at the moment. So I think we still, and part of the problem might be that manual therapy, exercise, cupping, needles are not going to help everybody. And actually, they're probably not great fixes for chronic pain. You know, until we have to accept that some people, they are not primed at the moment to get out of pain. Maybe in 10 years' time, 15 years' time, 20 years' time, we're going to have better interventions, different interventions. It might be things like, you know, we're seeing the kind of fat loss drugs, aren't we, at the moment? They seem to have anti-inflammatory effects for some people. You know, they're changing our ecosystem. But at the moment, there is a significant portion of people that we can probably help their disability. We can probably help their psychology, but we're not so good currently at helping their pain. And I don't know what the answer to that is. I don't think it's better techniques. Right? You know, I think that's the challenge that we have. It's recognizing pain is not just a reflection of some form of biomechanics. It's not likely to be fixed by a really simple intervention. Sometimes we are not there quite yet. And that kind of much longer term research and looking at some of these wider factors, I think can be really important.
Yes.
What we have been, bye.
Pode falar.
What we have in the end is that some patients are more able for some treatments, and some predictive factors we must learn more at research to subgroup the patients that should be better.
Maybe. Now, at the moment, subgrouping research is good at subgrouping, but it doesn't seem to be good at improving outcomes. So there is still a challenge there, right? So we can, and the question might be, are we good enough at subgrouping? Or is the best way to subgroup the individual themselves, right? Do you see what I mean? So do you subgroup so far that it's just a really good individual assessment? You know, we can have these really broad subgroups, and people do things like pain descriptors, don't they? Is it neuropathic? Is it nociceptive? Is it nociplastic? They are pain descriptors. Has that improved outcomes yet. And it doesn't seem to. So people like things to be neat and tidy. They like to say, this is the problem, this is the treatment. And that's great. But when we look at lots of different classification techniques or things, whether they're psychological from start back, whether they're mechanical like Mackenzie, none of them quite yet have proven to be the answer. Sometimes are they better for clinicians than they are for patients? Do they give people a system? Do they give people a way of working that helps them? Does that always improve outcomes is the question. And that's the challenge.
I believe that one of the answers for this conundrum, we can say that, is
good word,
timing. What I think is we as thinking individuals, we have this very Cartesian way of thinking. We have to explain everything. We have to group everything in patterns to see a way of working with the pattern. That's my opinion. And what I see along the time I've been working with different types of patients, I believe that we have to look for the timing. What I mean is, for every patient, we have a perfect timing to intervene, a perfect time to apply a manual therapy, to recommend exercise, to use taping, dry needling, cupping, whatever. But the thing is, why? When you think why a patient improves when you do just infrared therapy and another one with a click, and they have the same condition. I believe that's timing. That's the readiness that that person has to accept the therapy he's receiving, and of course, ruling out the risks and everything else. So as we are moving away from the anatomic possibilism and going into the comprehension of overlapping conditions and contextual factors working on an individual, all comes to timing. Is it the time to use this technique? Is it the time to say to this person that you need to go to a psychologist, a psychiatrist, to go to the gym? And when's the proper time to tell tell a patient what to do to keep improving and reach the goal he or she wants to reach, the well-being, the pain-free situation, everything. How do you think about that?
So I certainly think if we think about something like behavior change, that is definitely to some degree about timing, isn't it? That, you know, some patients are more ready, they are more able to, you know, change, or they're more open to change.
Or even cope with the situation for a time the long enough to change and be better.
Yeah, well, again, that might be about what's going on in your life. It might be about what's happened previously. It might be about meeting an osteopath that you really respect and like, and you trust them, and you're willing to change, right? So there is that in the sense of timing. Now, I think time is also not our friend sometimes, because if you meet someone who's had years of failed treatment, low motivation, you know, they have lots of nociplastic change within their system. They have levels of comorbidity. Sometimes, you know, and actually one of the reasons I believe pain becomes chronic actually is mismanagement. So we know that when things are mismanaged, and there was a good JAMA paper on this a few years ago, you know, people get lots of overdiagnosis, overtreatment. It has an effect on the outcome. So the problem is that some people have a really long history of intervention and diagnosis and medicalisation. And so one of the problems is they may meet the right person at the wrong time. It might be that you meet someone who's really, really good and brilliant and biopsychosocial and all of these things, but you meet them at a time when your system has been changed, it's been altered. There are lots of factors that are hindering recovery. So time can be really, really friendly. And I think the best thing that would happen is if you have a first-time incidence of back pain and you meet a really good therapist, whatever they are, and they are kind and caring and communicative, they treat in a way that is empowering, they allow people to have their values and their beliefs, right? So sometimes I think the problem is of timing is all of the shit that comes before. And when they meet someone that is a good therapist and has all of these positive thoughts and knowledge, sometimes it might be there is too much time has happened. So I agree with you in the sense that timing can be a key, but I think timing can also be our enemy as well, unfortunately.
Yeah, of course.
And how can the educators in osteopathy, physiotherapy, integrate the lessons from this research, from these psychological factors into training, so future clinicians are better equipped? How can we put that in education form?
Yeah, I had a conversation recently with a guy from who ran a university, actually, who ran they ran the physio department in a British university, and we sat and we talked about this for quite a long time. So I think the point here is, you know, right. So there's two ways that this is viewed. One is, let's get our young clinicians really, really early to have better, wider knowledge, to understand the role of health, to understand the role of pathology, to understand the role of psychology. So how do we get them thinking like that at the beginning? And for me, that is one of the keys, is that we are creating a knowledge at the very, very beginning that reflects reality, that reflects that most people with chronic pain have comorbidity, right? They're not just going to go out and exercise tomorrow and run a marathon and do this, you know. But it seems to be a dominant knowledge is that let's start it really simply. We need to start with the basics, and then at some point we can introduce it. And actually, for me, I don't think that achieves the outcomes that we want. So, you know, I think that to some degree, we have to get the new people as early as possible to reflect the good knowledge. But the problem is education can be really, you know, universities take time to change. They need to be driven by really inspirational people. So for me, how do we get really good, up-to-date research and models of human function into education early? How do we get the principles of great assessment? How do we get the principles of great communication? How do we get a lifelong, deeper learning perspective? How do we get people to read research regularly? For me, it's about the principles of rehab, not the details. And I think what we do is we start with the details. Where's the spinous process? Or, you know, where's the tibia? Or, you know, we start with the details to some degree, and we don't start with the concepts and principles of great rehabilitation. So for me, the first year of a degree would be, how do we get the basic principles in there, not the technique or the special test or the anatomy? You know, I think we need to flip education on its head almost.
I think I don't know how about England, but here in Brazil we have the same problem, and I think for to get it in the field of changing. We have a problem of the teachers today don't have enough knowledge about doing that. Do you think in England we have a different scenario, or it seems like here?
So partly, I think being in education is about understanding the education system. That's what part of the job. The job isn't being a clinician, right? So, but do great clinicians always make good teachers? So there's the other challenge that we have, right? So I think to some degree, one of the biggest skills that I think you have to have is how well you work with people. And actually, I think that's a human skill. That's not a clinical skill. That could be, you could be a plumber or an electrician and be great at dealing with people.
We could say that we learn how to work with people just with beer. It's better.
Yes, well, yes. Maybe red wine. Maybe red wine is better. I know. Yeah.
Could be.
Same vibe.
Yeah.
But I think sometimes with teachers we say, oh, they don't do enough clinical practice, and then with clinicians we could say, oh, they're not very good teachers. So it goes kind of both ways. What actually I think what we should be is thinking about how do we solve the problem, not just criticize the problem to some degree, because I see that quite I am now more of an educator than I am a clinician, and I'm quite happy with that. I feel that's where my skill set is. I am probably, and you could say, if you're not very good at it, teach, and I'm fine. That's fine. That's fine with me. And but being an educator is also about being inspirational. Not just the information that I give you. It's also how do we inspire people to learn? How do we inspire people to be open to learning? Not just, here's the technique I use every day in clinic. I don't give a shit which technique you use. I couldn't care less. Because what you do and what I do clinically may be very different. Who is to say which is better? Has someone done an RCT to say this guy is better than this guy is better than this guy? Yeah. I don't think so. Right? But I think what we need, is people actually that are inspirational, that inspire people to learn and do better, and that inspire people to have better knowledge. So teaching is not about how clever you are. It's about how you inspire other people. And so if I was going to think about what I teach, it's not groundbreaking. It really isn't. I have no special techniques in my sleeve that I pull out, right? I don't think what I do is any better than anyone else, but people do seem to like me teaching it. And they do seem to be inspired sometimes by what I say. And I think that we also need to look at that as a factor, not just what technique you're teaching or what knowledge or research you're teaching. A great teacher is about inspiration.
For sure. I totally agree with that.
How do you do that today in this AI time when students just don't want to learn? They go to the ChatGPT, the Perplexity, the Gemini, and just ask, and they have the answer. It's just the fact is people just don't want to read anymore, don't want to study anymore.
Which is why when you asked me for my nostalgic moment,
yeah,
people to go back to reading blogs even is powerful, right? Because if you can't read the research, well, read something a little bit shorter that may summarize some research. So the big problem we have is society is being shaped in a different way. We have immediacy. We have short attention spans, right? And again, that suits people that run platforms. It suits the politics. It suits the economics. And we are the downstream effect of that, aren't we? We are feeling that downstream, that we have less deep learning, and we need to still promote that deep learning. And that's what I try to do simply by putting up a research paper and talking about it, is just highlighting some of those things.
And how frustrated are you when you're trying to teach something that makes sense, principles, foundations, and people just want to learn the technique?
I'm quite lucky. I don't think many people come to my courses expecting that education experience.
You really don't know how lucky you are. You really don't know.
I know this. So it's like a selection bias, isn't it?
Yeah, for sure.
It's a selection bias.
Yeah.
And it works for me. It works for me.
That's okay for me. That's
It
okay.
makes you happy?
Yeah, it makes me happy. And to some degree, I have a slide at the beginning of my course that says it's okay to disagree, but be open to learning. So I am happy if you go on my course and get to the end and say, that was terrible. It might be that you didn't agree with me. You need something else to inspire you or to teach you. Not every type of teaching is right for everybody. That's fine. We have to accept that, don't we? But I would like people to be open to learning. And I think a lot of the time, especially people that are quite smart, are not always open to other perspectives. And can we be a little bit more open to listening to each other, but it's okay to disagree? So I'm going to listen to you. I'm going to pay you the respect that you deserve, but I might not agree.
Yeah.
Whereas now I think what we get is, I don't agree, so I'm going to tell the world, and I'm going to show you all the things where you're, and actually you can, information is adjustable, it's adaptable. Sometimes it's okay. We have to accept other people's opinions and ideas, but we don't have to agree with them. And again, if I had students, first year physio, osteo, whatever students, that would be a founding principle. I would love to stand up and say, if we all agreed all of the time, it would be really fucking boring. Life would be really boring. And there probably are many ways to help people, whether it's exercise, manual therapy, whatever, right? They probably share similarities.
That's what we're trying to do with our community of osteopathy here, me and Leo. And we're trying to say, it doesn't matter the technique you use and how you perform the technique. What really matters is, do you understand what's happening? Do you see the whole picture? Do you understand how you will drive your patient from this point to this one, promoting health, making him or her better? You have to understand how the things in her life or his life are working to leave him at this point today. And you have to move from this point to a better one. And it's not doing a specific technique, performing an act, a grain gesture by clicking a neck, a lumbar, whatever, or applying needles. It's all about understanding what's happening there.
This is one of the problems we have in education, I think, is that people want to know exactly what Ben does or Leonardo does or Adam does. And actually, why does that matter? What really matters is what you do and what you do to this specific person. And that might look differently, one patient to another. If everything you do with every patient looks the same, I would say that's probably not as effective as it could be.
Yeah, you're the problem.
Well, potentially, but, you know, I would say sometimes my education isn't always do this, this is the test, this is the fix, this is the exercise. And that really frustrates some people. And I get it. They want to know exactly what to do. Sometimes I don't even know what I'm going to do, right? I need to listen. You need to think. Yeah.
Many times.
Yeah, okay, many times. But so, you know, what does Ben do exactly in clinic? I have no idea. It depends on the patient and the time. But if you don't show exactly what you do, your method, then you're not very good, right? That's sometimes the way we look at education. Whereas actually being genuine, being authentic, being adaptable, being flexible are really powerful skills. And, you know, it might be that 10 patients look different. You give 10 different types of therapy, right? Because they might need 10 different things. And, you know, I think that it's that flexibility. Sometimes the best thing that we can do is learn what not to do, not always what to do.
Yeah.
What do we remove? What do we remove, you know? Do I need to do shortwave diathermy? Do I need to do heat packs? You know, are they going to move the needle? Probably not. But exactly which exercise you're going to do, I have no idea. Yeah. That depends on you and your life and your, you know, so we need to learn when to be less flexible in terms of, you know, what to subtract, but then also learn to be where to be flexible. You know, if you're using the same pain metaphor with every patient, then that's probably, again, not great rehab, because metaphors sometimes just go, right? So communication is flexible. Assessment to some degree is flexible. You know, you could say there's a constant that you're going to make sure you're as safe as possible. You're going to make sure that, you know, there isn't something serious there. You know, that's great. But beyond that, I think that level of flexibility and individuality is a really good thing. Why would we want everyone to do the same thing in the same way? That sounds like bullshit to me.
So it's going to be a boring world.
Well, but you think about this. You know, I think there are lots of systems and methods that are trying to standardize and minimize. And I understand why they do it, because people feel more comfortable having direction and they want to know what to do and when to do. It's control.
It's all about control.
Minimizing uncertainty. Uncertainty equals anxiety, whether you're a patient or a clinician. And we are always trying to minimize uncertainty and anxiety.
You had this post this week, right?
Pardon?
You did a post about uncertainty, right?
Yeah, I love, but no one cared.
I did.
You did. Yes. Well, thank you, Leonardo. I appreciate that, my friend. But these are not subjects that people care about.
No, not at all.
They want to know more. What's the best? You know, what test tells me whether it's a disc? That's what they want to know, right? Not that actually you need to tolerate. And sometimes you can't know whether it's a disc or a facet or a, you know, because that's maybe where we create false certainty. And sometimes that could be problematic, not always beneficial. Now that person might want to scan just to make sure it's the disc. And is that positive? Maybe not.
I believe what makes a good professional today is being open-minded, having an active listening, having compassion, and not rushing things out. Take the time, listen to your patient, be open-minded to what he's saying to you. Just don't judge, just listen. And then when he's done talking, then you can start understanding what's going on. Have a compassion, because when you have compassion, you're going to help that person. It's not about technique. It's not about working with the hands, with the dumbbells, the barbells. It's about listening and seeing the perfect time to do something that's positive. And maybe, as you said, sometimes it's just doing nothing.
I mean, yeah, yes, yeah. Yeah, but these aren't always skills that people value. That's the problem we have.
Not at all.
Yeah, it's that listening, you know, is not easy, actually, especially when you've got a very low attention span. You know, it's probably very difficult to go from Instagram and Twitter to then being a clear mind and listening. You know, it's also about preparation. But we need to value those things. And that's the point of how do we get the kids today and take them and say, this is what you need to value a little bit more. You know, if we don't teach listening as a good valued thing, people will not value it. If you teach technique over communication, people will want technique over communication. So I think this starts with what do we promote? And at the moment, you know, I would like to think I'm trying to do that. I'm trying to lead this in my own way. But it also, you come up against lots of things that are not thinking in that way, right? So, you know, that for me is the big challenge, is how do we shift what people think is important?
Yeah,
for sure. Do you can we close the paper here?
Of course.
Do you have anything else to say about this? We just start with that, then we became a clinician chat. That's awesome.
They're the best discussions, buddy. Don't worry about the details. We can just, you know, the paper is a discussion starter, because otherwise you get into the, you know, we can get into the details and everyone will just go to sleep. And, you know, this is a much better discussion.
And we have also a question that
okay, go for it.
Imagine now if you have the power of being listened to everyone, every physical therapist, every osteopath in the world now are going to receive one message from you. Which message do you want to send for everybody? 100% of reading.
Yeah. Be open to learning. Being open to learn is that, and I say this to myself, not just to everybody else. In fact, for me, the most important person to give this message to is me. And I think it's so important that we remain people that listen to others. We don't have to agree, but if we close our minds and think we've finished and we know everything, then I think we're going to really, really struggle. And I see this often on social media. In fact, from the people that think they're the smartest, is that they are very, very poor at accepting or listening to other people's opinions. And that sometimes you don't have to agree, but sometimes you do have to listen, because there might be, in fact, so many times I've initially disagreed and then thought about it, and it hurts, it burns inside. But sometimes it changes our mind as well. And if we're not open, if we don't have an element of growth mindset, that we're still teachable, we're still learning, other people's opinions matter, that I think that's where we just start to plateau. When we start to think we are the authority and we are the people that everyone should listen to, is when we start to fail, because then we've become, our growth has dropped. So how do we remain teachable? How do we remain open to changing our minds? And sometimes that can be painful and we don't like it, but it can be really important. When you don't have any more growth left, then what is life?
That's the beginning of the fall. Yeah.
So it's being open, I think.
Very, very good.
I'll just translate. O que o Ben disse é que tenha a mente aberta para aprender. Aprenda, procure aprender sempre. Porque o dia que você achar que você sabe tudo, acabou a sua trajetória profissional. That's it. That's fantastic.
That's what I would have said. If I spoke Portuguese, I'd have said exactly that.
Yeah.
Yeah, I'm sure of it.
And now we have our last question that we think is the most important one, that Leo has accountability of all the answers of all the people that we invited here. So Leo, please do your question.
That's the question that changes everything. It influences all of it. Ben, what is the pseudoscience that from which you have the most fun?
Yeah, so look, I think this goes back to when we talked about non-specificity, right? Because I think there are lots and lots of pseudosciences, right? There are lots of explanations for why people hurt, whether it's biomechanical, fascial, posture, trigger points, right? And they all attempt to explain the problem, don't they? Right? So I don't know. I think we need, the biggest antidote to pseudoscience is proper science. Right? So I think one of the big challenges we have, is that there are so many of these pseudo explanations, pseudo diagnosis. And one of the reasons they exist is because we don't understand the problem. We don't understand things like non-specific effects. We don't understand that pain can be modulated in a million different ways. And what that allows is all of these pseudo-scientific explanations for pain and for treatment. So I don't know if I mean, I dislike them all equally. But it reminds me that people love an explanation. They want to know why, because it minimizes uncertainty. It minimizes anxiety. So in that sense,
have the control.
Yeah, they have the control. And that's the point, is that sometimes that control doesn't equal a better outcome. That's important to recognize. You can have temporal control, right? But you could say lots of systems work via giving someone an element of control. You could say something like, this might be controversial, McKenzie, that people get an exercise to help them. I don't know whether that's, that's the right exercise, but one of the reasons that it helps might be that people have an element of control, that they have something to do. They have something they can work on. They have that, maybe that's a locus of control. So, I think that you could say manual therapy has elements of pseudoscience. Exercise has elements of pseudoscience. Massage has elements of pseudoscience, because all of them have some bullshit explanations that go with them. So a lot of what gets told and what people learn, unfortunately, is pseudoscience. And what we need to do is get better at actual science and tolerating uncertainty to help us. That's what we need, basic scientific literacy and knowledge. And the more we have that, I think the less pseudoscience we will have. And it's a bit like asking, what's your favorite flavor of bullshit? Right?
I have a lot.
Yeah, but they all taste like shit.
For our guests, company is the best.
Yeah, but all bullshit tastes like shit. Right? And for me, so pseudoscience is the same. Which flavor of pseudoscience do I like or dislike? Well, I dislike them all fairly equally. But I think we also need, just to improve our knowledge of things like, you know, non-specific effects, we need to improve our knowledge of basic causation and just basic scientific plausibility as well. And if we can do that, hopefully pseudoscience, you know, goes away. But essentially, pseudoscience exists to minimize uncertainty.
Yeah.
And that's the biggest challenge. How do we minimize uncertainty?
And here we go again.
All right.
Nothing new here.
It was
nothing
great. Do you know David Puta?
I've come across him once or twice.
Yeah. It would be nice to put you two together to discuss the principles, the validations. It'll be interesting.
I'm sure it would be fascinating. It's not something that's going to happen, though.
For sure, for us. I don't know. I don't know the audience, but for us, it's going to be fine.
I'm sure it would be great.
Ben, we just want to thank you very much for the knowledge that you share with us, for your time, for your all the stuff that we discuss about clinicians, and we hope we could have you here more times. Brazilian time, London time, I don't know, but we are going to arrange it.
Yeah, well, I have been once to Rio. I went and taught in Rio in 2017.
Oh, really?
Yeah, yeah. So I have taught in Brazil. Yeah, it was great.
It's time to come back.
I stayed at the Copacabana.
Yeah, we are going to bring you here again.
Ben, okay, it was very nice to have you here. We just have to thank you for taking time to be with us. It was fascinating discovering you. You're an old school professional like us, and we sure enjoyed having your opinion here. And we agree on so many subjects. And truly, we would like to invite you to come back again with another guest to discuss manual therapy, physical therapy, exercise, everything that's going on our profession and the future, and what we can do to change it, or just to talk shit and say bad things about the others. But I am pleased to have you here.
I'm an expert in talking shit. That's an expertise of mine.
Maybe you could convince Adam to join us also. That would be great.
Yes, we both talk shit. We are aware of it.
We know. We like Adam. We like Adam.
Good. Thank you. Thank you for having me.
Okay, you can have your final considerations, please.
Oh, no. My final considerations are, thanks for giving me the space to communicate my thoughts and ideas. And, it's important for people to realize it's just my opinions, right? And you can have another opinion and that's okay.
That's life.
Very nice.
That's life. We have our opinions, we disagree. But I think, at the end of the day, we disagree on stuff that's not that important, like manual therapy and exercise. Is it really that important? Probably not.
Yeah, for sure. Thank you again.
Good. Thank you, guys.
Pessoal, seguinte, terminamos aqui esse episódio. Espero que vocês tenham gostado. Léo, eu espero que você tenha gostado tanto quanto eu desse episódio. Certo?
Fantástico. Cabeça fantástica.
Sigam @CorKinetic no Instagram e no Twitter, no X.
Aqui embaixo no link.
tá? Agora vocês conhecem o Ben aqui, vocês vão perceber que ele é muito melhor no podcast do que no Instagram, que ele pode ser um pouco mais duro com vocês. Mas assim é a vida, tá, gente?
É isso. Obrigado, galera, por mais uma vez estarem com a gente no nosso episódio. Um abração. Até a próxima.
Thank you. See you next time.
Thank you, Ben.